Shomshila, you can start.
All right. Thank you, Dr. Ajit Babu. Sonali very well presented and a beautiful case. The clinical pictures are very good. But I would say that that was not a hypopion actually, that was a fibrin reaction that the patient had. So it was not really hypopion. But the points that Dr. Ajit Babu said on measuring the hypopion, I think that was the point. So I thought that you have pretty much done a very good, it's sort of an introduction of the topic for me, Sonali. So I'll go through a few more points and hopefully, by the end of my talk itself, maybe, so you were unlucky that you were the opening batswoman. So the others will be luckier than you. So you had to face very tough bowlers, and they have some tricks up their sleeve now, so they can modify their presentations. Certainly they can take off the patient's name, for example, and keep the identity not revealed. So that thing they can do. So good job, Sonali. So I'm going to talk mainly about clinical features, and I actually didn't think much about investigation, but now I see I have to really highlight the principles of investigation, and I'm going to highlight the principles of management. And I'll try to keep the talk maybe within 30 minutes. So I might just skip a few slides, which I think that may not be very important or useful. So this Sonali had covered nicely the onset duration and the response. When I say response, I mean to the previous therapy that the patient, so to us, the patient comes referred. I'm sure even in medical college, they might have consulted elsewhere and come to you. The second part in history is that we should also ask, is it a primary or a recurrent episode? And if the patient had received treatment somewhere, frequently you'll see that they were missed, the diagnosis was missed as conjunctivitis, and they were started on antibiotics. And this is a very frequent finding. So then they come to us because sometimes it starts with congestion, and later the cells in the KPs and everything are picked up. So if the ophthalmologist is not suspecting uveitis, they might just treat them. So we need to see whether they were given antibiotics and was there any response just to that. So the one thing that in history is we keep saying recurrent. So even Dr. Shamisha has pointed out that you have to say whether it's acute or recurrent or in your diagnosis as well. So we need to highlight whether is it really recurrent episode or was it inadequate therapy to start with? And also we need to get the history. Is it isolated, just an ocular entity? Or as you highlighted in your case, that there was some systemic entity as well for the patient. So this is, when we move on to examination, what are the top things we're going to do in examination? So the 4 things that I always think of is, number 1, is a red eye due to uveitis? Because I'm sitting in the uveitis clinic, so patients get downstream to me, but you're sitting in a general ophthalmology kind of a setup, or whoever, you could be a practitioner where any kind of patient walks in. So you need to distinguish between uveitis and other causes of red eye. Once you are with a brief examination and clinical history, you're pretty sure it's uveitis, then you're going to further localize what is the site of inflammation. As it was pointed out in the diagnosis, you need to know anterior, intermediate, posterior uveitis, panuveitis. And equally important is to know whether it's granulomatous or non-granulomatous, because that is the pathology of the disease. That will give you what is the etiology, that will tell you about the clinical findings, that will tell you what investigations to do and how to manage this patient. So point number 3 is very, very important. And of course, you have to do a comprehensive anterior and posterior segment examination. Leave no stone unturned, because you want to pick up everything about the patient, which you did very beautifully in the case. You saw there was some mild disc hyperemia or edema. The patient could have had cystoid macular edema, although it was anterior uveitis. So even if it's anterior uveitis, you must do a comprehensive examination for the patient, including intraocular pressures, sometimes gonioscopy, etc., etc. So coming back again to the cause, to this sort of a buzzword of recurrence. What is recurrence? Recurrence means that the patient had an episode in the past which was adequately treated, and it reached the level of quiescence, meaning there were no cells and no flare, and then there's an interval, and then again the patient has a new episode. So that is recurrence. But there are various causes of what you can call a pseudo-recurrence. That is inadequate treatment. Either the dose was very low. I would say, for example, for your case with the fibrinous reaction release, the dose of 6 times is low actually. You would ramp it up to a higher dose, at least in the first 1 week. I might have given atropine to this patient. So the duration may have been very short, because the patient may sometimes just stop. They'll get relief and they stop the medications. And sometimes what you think is pseudo-recurrence is actually because the patient has more than anterior uveitis. So there can be intermediate uveitis, or posterior panuveitis. That is where your very good thorough examination comes into play. So the very early panuveitis, certain entities can just present as a very subtle anterior chamber cells and so on. And if we don't examine comprehensively, we might miss it. So we give topical steroids, the patient comes back with what we think is recurrence, but it's a pseudo recurrence. And then the last situation that we often see is that the cause is still present. We're not addressing it. So in the patient that Sonali presented, it was looking like a case probably, HLA-B27 related, because it was non-granulomatous anterior uveitis with that typical fibrin reaction. And the patient did have history of low back pain, youngish patient. But it could be viral, and viral will not improve. It will not go away unless you give antiviral treatment. Or let's say we have done cataract surgery for the patient and the IOL haptics are malpositioned, or there is some residual lens matter, or we had a PC rent and we didn't refer the case to Dr. Ajit Babu, but the patient has dropped nuclear fragments. So these patients will have continued to keep having recurrent uveitis. So we have to make sure that we understand that recurrence means that the patient went back to quiescence and comes back with an episode, as opposed to a sort of a flare-up of the disease. This is a pseudo recurrence, which are all the conditions I've listed here. So the true reactivations is exactly the case that we saw, like HLA-B27 and other such purely immune-mediated etiology. Coming a little bit to, you did take family history, you told us where the geographical history, you told us where the patient is from. We do know certain diseases have a predilection in certain populations, racially also and geography-wise also. Behçet's disease being one of the classical entities that is there along the so-called Silk Route. In certain countries, the disease is much more common in Japan, in Turkey, and so on. Family history of some of the other patients in the same family could be HLA-B27 positive. I've also seen that there are families where the parents or some other member has rheumatoid arthritis and the patient who's come to you with HLA-B27. So you could have family history like that. When you talk about the patient's age, which Sonali did in the first case, so we had a younger patient. So we need to think of the disease differently when we see a pediatric patient versus a young patient versus a middle-aged versus a very elderly patient. So the two extremes, a pediatric patient has a different etiology and an elderly patient could have just a masquerade or something very ominous like that. So these are the two extremes we need to watch out for. Male patients tend to be positive for HLA-B27. So female patients could have different disease. The race, again, VKH is more common in the pigmented population, although it's not an anterior uveitis. But race, again, plays a role in certain diseases. And of course, you mentioned the personal history and various other systemic diseases, because these are important for us to manage the patient. Let's say that my anterior uveitis patient, the disease doesn't get better. And so I feel I have to use oral steroids in that rare patient. So he should not turn out to be diabetic. So I do need to know everything about the patient. So in the textbooks, it's very confusing. They say that you should look at the entire systemic, examination should be done. And even you were asked in your case, Sonali, that what exactly did you do? What did you do in your examination? So I used to get very confused when I was a resident. And I used to think that it's such a difficult, how can you examine the entire patient and figure out what's happening? So then I broke it down to what I should ask and what system I should look for. So I would look for the joints, pulmonary system, GI, dermat, neuro, and genitourinary. So these are the systems that I would look for. Of course, it's a backward way. First, you ask the patient questions, think of what the disease is, and then you ask additional questions here. It doesn't go in the series that normally you take all sorts of history and then you go on to examination. It doesn't follow that rule. So when you talk about the joints or arthralgia or low back pain or fleeting joint pain, patient can have it in the shoulders, so it's more, or they can have it distal in the small joints. So it can either be proximal in the large joints. So we have to ask for history of arthralgia and just take our eyes off from the slit lamp and look at the patient as a whole. Sometimes you might have something as disfiguring as this, which we rarely see, staring at you. So this was one of my patients of rheumatoid arthritis. Very rare to have anterior uveitis in rheumatoid arthritis. This patient had it. So in arthralgias, when patient gives history of arthralgias, so depending on the age and where the pain is, so you think of HLA-B27. If it's a pediatric patient, you think of GIA. If it's a female patient like this lady here, you think of rheumatoid arthritis. Also, sarcoidosis can have joint inflammation, and as well as an entity called psoriatic arthritis. So psoriasis with the arthritis component, and they all have uveitis. When you think of pulmonary, again, sarcoidosis, tuberculosis, patients with interstitial lung disease sometimes present with anterior uveitis. When you think of gastrointestinal, so the patient complains of gastrointestinal symptoms, then you can have Crohn's disease, IBD, as well as tuberculosis. And these are the patients, sometimes they come to you with anterior uveitis. So this is another patient of mine who's elderly patient with HLA-B27 positivity. So this is an ankylosing spondylitis. The patient walks in with the diagnosis literally written on the patient. So you cannot miss this. The patient comes in with this vent deformity in the uvea clinic, or it comes to your ophthalmic clinic, you know that this patient has anterior uveitis. And this patient would have had uveitis literally all their lives. Every year they have an episode or two because the systemic disease has not been treated. That's why the patient has gone into this flexion deformity. So the other three systems I mentioned earlier, to go through it a little faster, would be dermatological. So let's say the patient has some skin manifestations, has psoriasis, could be Hansen's or some other diseases that comes under dermatology, and they may have anterior uveitis. So these are what I search for. So certain diseases have neurological symptoms, and genital urinary or aware of Reiter's disease, as well as syphilis and penile ulcers and Behçet's disease. So there's a patient with trophic ulcer who had Hansen's disease. There's another patient with Hansen's. Look at the thickened ear lobe that the patient had. So both these patients had anterior uveitis. And this is another patient who presented with anterior uveitis and extensively, and there was enough evidence of tuberculosis also. The patient had bone focus with tuberculoma in the pulmonary system, also turned out to have CNS tuberculoma. This is one of the rare cases. So the patient had neurological symptoms. That's how we came to the diagnosis. So these are the only 6 sort of components or compartments we need to look at. And when each patient presents with one of these 6 compartments, then these are some of the diseases that are commonly associated with anterior uveitis. Moving on to the clinical features. We know that there are classical clinical features: sudden onset, severe pain. It is quite a painful condition because the patient has cyclitis, and also the patient has circumcorneal congestion. So the patient comes in with the congested red eye. You'll have Keratic Precipitates, cell flare, fibrin. So you can't miss a patient with established anterior uveitis, but you can miss a patient who comes in only with that mild red eye or some other red eyes that the patient comes with, and you confuse it with uveitis. So just like during COVID, any patient who had cough, cold, fever, we were immediately thought of as COVID-19. But now that's not the case, right? So all red eyes, it's not necessary that it's going to be uveitis. So a little bit on the differential diagnosis of red eye. So of course, some red eyes, very obviously conjunctivitis, patient has foreign body or something. So those are very obvious, but some red eyes where you get confused. So epistemitis is one common confusing entity. Often I've had patients being diagnosed as anterior uveitis, although you won't have KPs and so on, but you will have a localized sort of a superficial congestion. And notice that you don't have that circumcorneal congestion. It's localized, it's inferior over here, wherever is episcleritis. So that is one good telltale sign that you know that this is not going to be anterior uveitis. You can have patients who present with nodular scleritis, like this patient here. Again, the focus is only around that nodule, that light-tick nodule, and it's not really circumcorneal at all. So that this was a rare case of nodular scleritis. You can also, then you can have patients who come in with, there is congestion, which is pretty much around the limbus, but this particular patient, in this particular patient, it was actually viral conjunctivitis. So there are more signs and symptoms that the patient had. You can also have just drug toxicity or contact lens wear or dry eye. Many causes for this very pale pink kind of a appearance of the eye. So when it's uveitis, you'll really know it's uveitis because you'll have a very congested, deeply congested eye. There will be diffuse congestion, but the maximum, so there'll be diffuse congestion all over, but the maximum congestion will be around the limbus, close to the limbus, so circumcorneal congestion. And sometimes scleritis, you can have diffuse scleritis, but you very rarely have KPs in scleritis. So that's a very close differential to anterior uveitis. And of course, you can have glaucoma, you can have severe chemical injury in ocular surface disease, and so on. So just to highlight that not all red eyes are uveitis. So what is uveitis? You have patients coming in with diffuse circumcorneal or also ciliary congestion. It can appear mild or moderate or severe, and you will have other signs of inflammation, which will be Keratic Precipitates and so on. So some more differential diagnosis. This is nothing. This is just very prominent coarse true vessels. It's an AV malformation, but sometimes it suddenly appears. So this can happen in very swarthy or sort of very thick-skinned, heavy, bulky individuals or hypertensive. This is whereas this is anterior uveitis. This patient has epistemitis, whereas this is a patient with a nodular lytic kind of a nodule, also has Keratic Precipitates. So has associated anterior uveitis, but the problem is the nodular scleritis part that the patient has. There's another case of nodular scleritis, and this is what you have in anterior uveitis. You have pigmented Keratic Precipitates and a very mildly congested eye. So the congestion in uveitis can vary. So we talked about red eye. We said that red eye, it means that it's kind of going to be uveitis. But we know also that you can have uveitis without red eye or the white eye uveitis. So the classic kind of cases where you have that is JIA. So in juvenile idiopathic arthritis, it has a very high association with uveitis. In the patients who are female, who have single joint inflammation, foci articular involvement, and who are ANA and RA positive. So this is a classical pattern. But in JIA, in male patients with negative RA or ANA, uveitis is very, very uncommon. So it's not commonly seen in JIA, but it's commonly seen in the subvariant of JIA that I mentioned. The other variant is viral anterior uveitis, very common to have these patients, commoner than you think. A lot of patients with unilateral anterior uveitis that doesn't go away, it keeps on recurring. So this could well be viral anterior uveitis. Again, there won't be a red eye. There may not be posterior synechiae, but there'll be high intraocular pressure. And Fuchs heterochromic uveitis, you know that the patient has a white eye, no posterior synechiae, and sort of a Keratic Precipitates which are stellate in nature. Some of the intermediate uveitis, they'll present mainly with the anterior uveitis component to start with. And some patients, when you've started treatment, so the eye looks very white, but the patient, you have to ask the history and they would say that it did start with a red eye. So this is a patient of viral anterior uveitis where there's not much to look at. There's some medium-sized to large Keratic Precipitates, but this patient had recurrent disease for 16 years before we did an AC tap and we got the therapy for going for this patient and the uveitis resolved. This is another patient who's a patient with Fuchs uveitis with the typical stellate Keratic Precipitates. And look at how the Keratic Precipitates are diffusely located. And also, I don't know if you can make out, but there's a subtle difference in the iris color. So most of our irises in Telangana and South India are deeply pigmented. So here it's a lighter pigmented. So there's a heterochromia kind of a situation here. And we talked about white eye uveitis in pediatric patients. So this is not JIA, but this is a sort of a BSK, idiopathic BSK that can be seen in children. So one of the findings that is there in JIA is here is BSK, but there is no uveitis. See how round the pupil is. So this was a differential diagnosis. This is JIA. The patient has band-shaped keratopathy just starting over there. Patient has occlusio as well as seclusio pupillae and also has a complicated cataract. And this patient needs everything, needs maximum medical therapy, immunomodulators, and so on. This was quite sad, actually. The other eye of this patient was already in hypotony. That's why you see that this horizontal sort of a band over there due to chronic hypotony. And the eye that I showed you first was a better eye for this patient. So we managed by starting the child on immunomodulators, and the patient underwent past lensectomy, vitrectomy, and subsequently did well with decent vision. There's one more case of, it is not JIA, but it is a pediatric patient who has very mild anterior segment inflammation. So there are posterior synechiae, and the test for JIA as well as the history of joint inflammation was not there for this patient. But this patient continues to have recurrent episodes and is now doing well with systemic immunomodulators. So Dr. Ajit Babu asked a very important question on Keratic Precipitates, and he asked, what is the location? What is the classical location? And there's a reason why he asked that. Because Keratic Precipitates classically are located in a triangular fashion, the R is triangle. And there's a reason for that. It's because of the convention currents that go on in the anterior chamber. So you have currents coming from up to down. And all these inflammatory elements are there in the aqueous, which is a modified aqueous. And as the currents are going, so it's literally like these cells which are heavy just keep getting thrown onto the cornea. And so they form these keratic precipitates, mainly in the inferior part because they're heavy due to gravity. And these are patients with large, this particular picture shows you large keratic precipitates in 2 such cases. Okay, so keratic precipitates, not every deposit on the cornea is a KP. So you can have many differential diagnoses for that. So in Fuchs endothelial dystrophy, you'll have diffuse pigments all over the cornea, not a KP. In pigmentary dispersion, so the difference for both of these look a little similar. So you'll have very fine and iris pigment colored little deposits on the endothelium. So don't confuse them as KPs. Then Krukenberg's spindle, it occurs in glaucoma. You can have drug deposits that look like keratic precipitates, pseudoexfoliative material on the cornea. And also there's a condition called posterior polymorphous dystrophy, where you have what looks like material, looks like KPs on the cornea. So what are keratic precipitates? You can have fine white keratic precipitates, like in the HLA-B27 case, probably like in Sonali's case, or you can have larger white or pigmented in granulomatous. So this is a patient with granulomatous pigmented keratic precipitates, what they call as mutton fat. So they're sort of a muddy, brownish to yellowish, very three-dimensional looking. So this is very classical. Either you suspect that the patient may have a tubercular etiology in this particular kind of situation. So what are the important clues you get about the disease from keratic precipitates? Why is it important? So you'll know whether the disease is recent versus old disease based on what the precipitates looks like. The fresh are three-dimensional, whereas the old would look flatter, and the resolved ones would look like pigments. So about the etiology, whether it's granulomatous or whether it's non-granulomatous. And in Epistemitis, you have a very sort of unique kind of keratic precipitates, which we call as microgranulomatous, which have stellate edges also. So the fresh versus old keratic precipitates, and these are some patients of viral uveitis and Fuchs heterochromic uveitis, where you have diffusely distributed keratic precipitates. So you were also asked, Sonali, about poor Sonali. She's become like the index piece. We ask everything to her now. So you were also asked about how do you measure the cell, how do you measure the cells in flare. So you know that there's a specific way, and you represent it in your presentation by saying that the cells were between a grade of 0 to 4 and so on, and you know how to do that. And hypopion is separately graded. So you from trace to the height of the hypopion is what you say. And also fibrin, like you had in that particular, or coagulum, whatever you want to call it, you had in that particular patient. So these are classical for all sorts of uveitis that you grade the cells in flare. You can have hypopion. It doesn't have to be an infection, but you can have hypopion uveitis in HLA-B27 uveitis, in Behçet's disease. So, and even in viral anterior uveitis, this is a child with viral anterior HSV uveitis, and child presented with hypopion, which would not go away with topical steroids, and we even give a short course of oral steroids. And we did an AC tab, and we were actually very frightened that we might get some lymphoma cells or something like that. Luckily for us, leukemia cells, but luckily for us, it was viral, and we started antiviral, and the patient did well. So flare, though it's hard to see, but flare is basically the dispersion of the light reflex in the turbid aqueous, which is changed due to uveitis. And you can also have pigments on the lens surface, which is also there in your case, in the case of one episode of uveitis. So I mentioned earlier, do gonioscopy, because sometimes there are these large nodules, but this is very obvious. It's a macro nodule. Sometimes you can see them. Other causes like retained lens matter, foreign bodies, etc. Coming to the iris, very briefly, you mentioned that in active disease you have muddy iris. Pupil sometimes often does not dilate because of inflammation, so it stays very small and myosed. You can have peripheral anterior synechiae, posterior synechiae, and you can have the seclusio and the occlusio pupillae, which is what I've shown you in these pictures over here. And this is a case of syphilis that we detected later after you've been investigated, and the patient had anterior uveitis and pupillary nodules in this case. So you know that in the books and also in patients and in the exams, you're asked what are Boussaka's nodules, what are Kopi's nodules. So they're both the same in terms of histopathology, but P for pupil, so they are at the pupillary edge, and Boussaka's are distributed over the iris. So there's another patient with Kopi's nodules because they're distributed along the pupil. So intraocular pressure, I'm not going to go into this in detail. It's just that in intraocular pressure, you can have high intraocular pressure or low intraocular pressure. Both of these are possible in the case of uveitis. Typically, in acute inflammation, you expect the patient to have low pressure, and that's because of the cyclitis component. But sometimes the patient, when they present with high pressure, then it's quite likely that either the patient has a pupillary block due to recurrent episodes, there are multiple posterior synechiae and iris bombing, or the patient could have a viral disease, and that's why the pressure is high. So, and the last thing is that you can have high pressure due to steroid response. So don't let steroid response be your first reason. So because then you'll not even use steroids for this patient, which is what the patient might need. So explore all other possibilities as well. So we looked at almost most of the components of this slit lamp examination, but for lens. And remember, one point about lens is that in a case of hypomature lens, it can be the cause of uveitis. So especially in the elderly patients. So think about that, keep that in your differential diagnosis. If you have an elderly patient who walks in with a very angry, inflamed eye and has a more than total cataract, has a hypomature cataract. So it's most likely to be a lens-induced uveitis. And of course, you will start topical steroid, but you also have to schedule for surgery for this patient. Whereas in all other cases, younger patients, you don't schedule them immediately for surgery when they have uveitis. And of course, Fuchs patients are the other group that present with cataract. But here it is different. The cataract is not the cause of Fuchs. And here, in fact, we can do very safe cataract surgery with good result. All right. So I was actually very keen to come to investigations because of the amount of money the patient is going to spend with the list of investigations that are given. So we must remember that in the role of lab investigations, luckily in anterior uveitis, is very limited, very limited. So it's not required. Most of the time, if it's a first episode of non-granulomatous uveitis, we can simply treat the patient. Like my mentor, Professor Narsingh Rao, used to always say that everybody is entitled to have one episode of uveitis in their life. And that's like just getting, some kind of immune trigger and you get an episode of uveitis. So he used to prefer not to investigate. I don't know if he's changed his practice now, but this was years ago when I was a fellow. So he used to not investigate if it was just one episode. But most of the time, even if I have the first episode of non-granulomatous, especially if it's a younger patient or male patient, I usually ask for an HLA-B27, especially if the patient can afford the 2,000 or 2,500, because it's one investigation that gives a lot of information. And if you have it positive, then you know exactly what the patient has. So even for the first episode, I do often ask for this one investigation of non-granulomatous. So you don't need investigations for very clear diagnosis like viral, Fuchs uveitis, lens-induced. And just like the dictum of if you have one single episode, maybe in an elderly individual, where again the immune system is dysregulated a little bit. So they or anecdotally, a lot of if you talk at fora with a lot of practitioners, they say that when the patient has been detected to have diabetes, then they develop some kind of inflammation, including uveitis. So for these patients, you may not have to investigate. So nothing, zero. When is it important is that we have young patients and we have positive systemic history. And of course, in granulomatous, we will do a basic workup, and then recurrent disease and post-op and pediatric. Post-op will have a different set of investigation, not the routine serological investigation. Pediatric patients, I kind of mentioned already. So coming to the actual place where you need to put your money, the postgraduates, is the actual investigation. So for non-granulomatous anterior uveitis, I usually get an HLA-B27 done, even if it's a male or a female, though you know that in female it's much less likely, but still. I usually never get X-ray SI joint done. That's not my job. It doesn't have to be done by the uveitis practitioner. Of course, in medical colleges, teaching hospitals, yes, I do agree. But most of the patients, depending on the history that we elicit, whether they have joint involvement or not. So if they do have joint involvement, they need to be taken care of by the rheumatologist. So I will refer them based on where they can go. They can go to the government set up, or if they have insurance, to whichever hospital. We have a good network of rheumatologists. So I do get the HLA-B27 done myself, and the rest of the investigations I leave it to the rheumatologist. And sometimes if the patient has certain history, then we might get an HLA-B51, B51, B52 done. So for non-granular matters, pretty much HLA-B27, that's it. No need of urine, routine microscopy, no need of CBC, ESR, all the other investigations that were mentioned. For pediatric patients, now, again, if I have some kind of symptomatology or some suspicion, because the pediatric patient has articular involvement. So the pediatric JIA, if they come with uveitis, they will have only 1 or 2 joint involvement, which they may not remember. So for these patients, I do get an RA and ANA done. And then I do refer them because, again, they need treatment for the systemic disease sometimes, and we need to start them on oral immunomodulators. So either if they really can't afford, then we take care of it ourselves. Our in-house physician helps us. But if they can have some kind of affordability or understanding, then we send them to an appropriate place that they can go to. So again, pediatric patients, very baseline, basic investigations done by us. And RA factor and SLE, that means ANA, are very, very, very rare causes of uveitis in the adult patient. They are of no value. So don't even advise RA and ANA for anterior uveitis in male or female. In male, it makes no sense really to advise ANA because SLE is literally 0 in male patients. So RA and ANA not needed. So again, I'm coming down to anterior uveitis, hardly anything is required in the non-granulomatous. And anything specific, it's viral and AC TAP and OCT, UVM. These are our ocular investigations that I would get done for these patients. Coming to granulomatous. So now I have the patient, if you remember those images I showed you with the thick, large keratic precipitates, the granulomatous keratic precipitates. They had some synechiae, they had some plastering of tissues. So these are the granulomatous disease patients that we're looking at. So for granulomatous, pretty much you have only 2 or 3 entities that cause it. So one is tuberculosis, the other one is sarcoidosis. So that's all we want to rule out. And we are not treating the tuberculosis or sarcoidosis. We want to rule out for the ocular component actually. So yes, always a Mantoux test. That's our basic baseline test. And we do get a chest X-ray done because we can't directly push the patient for an HRCT. It's expensive. But if sometimes the X-ray may show certain lesions, old lesions, so it helps us in our case. But usually it's a Mantoux test. How elevated is the Mantoux reading? How positive is it? And based on case to case, we may ask for IGRA, interferon gamma assay, or quantiferon TB gold, as it's also called. And HRCT test, we have to be very sensitive whether the patient can pay for it or not. But otherwise, Mantoux test and chest X-ray. Second is serum ACE. I get it done because it's a very inexpensive test. And I'd like to see how high it is. Is it very, very elevated or not? But serum ACE is no longer necessary or specific or sensitive for sarcoidosis. So in the latest literature, if you all go through it, the international committee has put down that it is not at all required to diagnose a patient of sarcoidosis. It doesn't help. What helps instead is a negative Mantoux, because it kind of means negative or a non-committal kind of Mantoux. It means that we're not looking at tubercular etiology. And HRCT tests are better diagnostic markers to look at the retrosternal, the mediastinal lymph nodes. So we are looking at ruling out tuberculosis, looking at ruling out sarcoidosis, and lastly, also syphilis. So I just showed you that example because this is something we perhaps missed because we just were doing VDRL, and VDRL is again a very not sensitive, not specific. So we have now moved to doing VDRL plus TPHA for these patients, and we've seen it comes positive in a lot of patients. The reason to chase a tubercular diagnosis or a syphilis diagnosis is because if you can give them treatment for that, your uveitis can stop. So that's the reason to do those tests. So I'll just very quickly, as quick as I can, go through this to just say that cortical steroids are, of course, the mainstay for anterior uveitis. It's a very rare case where I actually give oral steroids, very rare. So maybe out of maybe 10% of cases, I may give oral steroids for a week or 2. It's not for 1 month, 2 months, or 3 months. So that would be those cases where they have pretty severe inflammation and it's just not coming down with adequate topical medication, or the patient is very symptomatic and so on. And immunosuppressives for anterior uveitis in routine cases is very rare. But of course, in HLA-B27 cases, once in a while, we may need to give them immunomodulators for the ocular point of view. And in GI cases, of course, that's the mainstay. And cycloplegics, most of the time for me is usually atropine. Maybe I get more severe cases. Topical NSAIDs are kind of steroid sparing, and we can use them for a longer time. And then the specific therapy, like if it's anti-tubercular therapy or whatever, anti-syphilitic or antivirals and so on. So the dictum for topical steroids is use soon enough, often enough, and long enough. And there are various drugs which I've just listed in terms of the potency, with difluprednol being the most potent, but unfortunately can have very high predilection for secondary glaucoma, steroid-induced glaucoma, and of course cataract. And dexamethasone and betamethasone are unfortunately not available as monodrug preparation. They're usually available as combination. So the efficacy goes down. So when you want to deal with a disease which is so critical, so I don't want to use a drop which is a combination therapy. So instead I use prednisolone acetate because it's available as a monodrug, and start that typically at least 2 hourly, and step it down, call the patient back in 3 or 4 days, exactly as Dr. Ajit Babu mentioned. See the response, and if it's better, then step it down. If it's not better, continue with the same therapy. So you can't give 6, 5, 4, 3, 2, 1. So it'll be 2 hourly for the first 4 days, call the patient back, or 3 days, call the patient back, and then based on that. Sometimes you may step up to 1 hourly also if you think it's not working. Or sometimes if nothing has happened, then I might start using difluprednol instead. All right, so that's what I had to share. I'm hoping that some of the doubts I answered and cleared, and sort of used Sonali's case as a literally an index case to highlight points in my presentation.
So, Michelle, it's an excellent presentation. You covered most of the points actually here, and it's a good enlightening and learning lecture for students, definitely. And certain things which, if I consider I'm as a postgraduate, first of all, clinical examination, I asked her also, how do you measure the flare and cells and grading? These two things has not come up very clearly in your lecture. Can you enumerate for the benefit of the postgraduates?
So thanks, Dr. Ajit Babu. I think I did not go into specifics of examination, maybe because the focus, it was very large, broad.
I know that.
So it's measurement of cells and flare is very important. So you know that we have a scale of 0 to 4. So 0 meaning that there are no cells, and then it's followed by trace. How do you examine? So you have to take the slit lamp beam if you have, say, a hack strike. So you have a 10 and a 16x on that magnification. So you take it to 16x. Make the thinnest beam, which is a small beam, brightest beam, and shine it usually just above the pupil. So that's a good place to shine it, and put it a little oblique, so about 30 degrees. And through that slit that you've created, you try to literally count the cells. Now, you don't sit for half an hour and count 1, 2, 3, 4. That's not how you do it. That's sort of it's an estimate, actually. You don't count it numerically. So if there are, when you're seeing the aqueous currents as it's moving, and very occasionally you see 1 cell now, and then 2 cells, and sometimes you don't see any cells. That is trace. That is trace, so 0 to 5. Then the next is 1. So you see 1 cell every time wherever you move the beam, you see that there is always 1 cell, 2 cells, 5 cells. So that is 1 plus. And then you see, then you have the grading going on, where about 25 cells per beam. You can't really count 25 cells, but you have to estimate that. And then when there are too many cells, too numerous to count, then it goes to 4 plus. So that's a practical way of doing it. Although in any of the books, Kansky and so on, it'll actually give you 0 to 10, 10 to 25, and then more than 40 and so on. But that's not really how you can do it. So you have to look at whether it's trace, and then it's a very mild, like 2 to 5 to 10 cells swimming around, and then suddenly 40 cells, you can't count. So that is 4 plus, and then sometimes you can count, sometimes you can't. So that is 3 plus. Yes. That is how you actually do it practically. For flare, you have to see the iris pattern. So that is easier, just like how it's in the book. From no flare, where you can see the iris pattern very clearly, and everything is very turbid and all. That typically is very rare to happen. You can have it in endophthalmitis or something where nothing is visible. So that would be 4 plus, and then in between that. So depending on how much of the iris and the pupil you can see. So that is the way to do cells and flare assessment. And hypopyon is graded separately. So hypopyon, it's cells 1 to 4 and flare also, and then hypopyon, no hypopyon, and then the amount, the 1 plus 2 plus, depending on the height.
Yeah, thank you for that. Second is that you said investigations very pertinently. You have mentioned that first episode, non-granulomatous, try to treat directly rather than investigating. But I would add a little bit as you can take a good history.
Right.
By itself, it will be a very good investigative tool for you.
That's right.
History will serve you what is the etiology for this anterior uveitis. That is very, very important. However, she has very nicely enumerated which are the conditions where you will go for investigation. Even if it is first attack, and those are the cases you should go for investigation. And second is ocular investigations you have mentioned, but you have not clarified regarding the OCT, UBM, and AC tap.
Yeah. So all cases where, so this is again AC tap you do for, if we do have the appropriate microbiology setup or virology setup, it is not a must. So AC tap I reserve for patients where I'm suspecting viral anterior uveitis, but there are enough clinical clues also. So you can start therapy, but to get to the exact virus, whether it's CMV or HSV or VZV, so we can do an AC tap to get the virology studies for those patients. I'm talking because the topic is limited to anterior uveitis, so I'm not mentioning other reasons for AC tap.
Yes.
And OCT is mainly because in chronic cases, even with anterior uveitis, you can have cystoid macular edema with inadequate cases or recurrent cases. And sometimes actually speaking, ideally even an FFA, because sometimes what you think is anterior uveitis, sometimes you know that you have the vasculitis component, which is there, and that you can only pick up clinically. Either somebody like Dr. Ajit Babu can pick up when he examines, and certainly an FFA would be indicated in those cases. But that would not be an anterior uveitis, then that would be a vasculitis. So that's the reason to rule it out. And lastly, I brought out UBM, though I didn't elaborate, but that was for all the other differentials I've given. Let's say you have a malpositioned IOL, you have a suspected foreign body in the anterior chamber, or residual lens matter lodged somewhere, or a granuloma kind of a lesion of the iris. So those are the indications for UBM. I just wanted to bring out what else we can do for our patients.
Yeah. How do you suspect, Shobhashila, regarding the viral uveitis? This is very clinically, it's without investigations. I don't want to hear AC tap and all.
Right.
But how do you suspect? This is for the benefit of the postgraduates again, because it has a typical presentation with viral anterior uveitis.
So can I share some slides, or you'd like me to answer?
Yeah, you want to share, it's fine. It's just better to enumerate them so that this is again important clinically for them to recognize viral.
Right. So very quickly, I'll just make it very brief when I speak, but I'll just use the slides because it will make it easy. And when we talk about viral anterior uveitis, these are the top three, although there are some rare viruses, but it's herpes simplex, varicella zoster, and cytomegalovirus. The top three viruses that can cause viral anterior uveitis. Of course, Fuchs is also presumed to be, it has been shown in studies that it's due to rubella, so that's also a viral cause. So so you have patients coming in with recurrent anterior uveitis, and typically with moderate AC reaction and raised intraocular pressure. So the patients where we think it's HSV, they have recurrent, even they can have some keratitis lesions, they can have corneal scars, otherwise if not keratitis, they can have decreased corneal sensations, old dendritis and so on. So when you have a patient with corneal involvement and small medium KPs, and as well as moderate AC reaction and raised intraocular pressure, so this patient goes into the bracket of viral anterior uveitis, but of HSV etiology. And as I'm showing here, the second one is in VZV. Now, I'm talking about VZV, not HZO. You can have herpes zoster ophthalmicus with anterior uveitis. That is one way of having it. And the other entity is where you have recurrent episodes of anterior uveitis due to varicella zoster virus. And that is seen more frequently in immunocompromised individuals where there can be pseudodendrites, etc. And the AC reaction is there, but telltale sign would be this iris atrophic changes. So you have a patient with the recurrent anterior uveitis and iris atrophic changes. Again, you suspect a viral uveitis and more likely to be lesionary. Here also, the pressures are usually high. And the last entity, which is the rarest but most intriguing, because it's difficult to, because it doesn't respond to acyclovir or vallecyclovir. That's why it's difficult and it stays on. So here you have what was known as the coin shape. So the conglomerate of KPs resemble like a circular kind of a fashion. So they call it coin shaped KPs, but it just means very discrete kind of KPs. And the IUP spikes are the highest here. So you can have a patient having 60 millimeters of mercury pressure in one eye, usually unilateral, usually younger patients. And slowly the specular counts show that the endothelium is affected. So it goes, the endothelial cells keep getting compromised. And this is the case of CMA. So any patient presenting with recurrent anterior uveitis with small few KPs diffuse and very high pressure, pupil can be no changes on the pupil or iris, or there can be moth-eaten pattern. So this fits into viral anterior uveitis. And it is much more common than we think it is.
Yeah, thank you for highlighting that. Because clinically, while you are treating not all anterior uveitis, you will treat only with steroids. In viral, probably you may have to consider steroid as well as antiviral treatments in these cases. Otherwise, they will go into recurrences.
Right.
And OCT in cases of anterior uveitis, mostly if the vision is all right or it is collaborating with the anterior uveitis severity, then probably it is not required. But otherwise, if there is a decreased vision over the clinical picture, then you should go for OCT just to rule out the cystoid macular edema. Any other questions from postgraduates now?
Yeah, I think
they are very silent. Actually, this whole exercise is for them.
Yeah.
And I'm sitting
Excuse
here
me, sir.
for them. Yeah.
Excuse me, sir. May I have a question?
Yeah, please.
Ma'am, what is the use of, or what is the use case of midricane number 2 subconjunctival injection in acute anterior uveitis? When do we use it actually?
So Arnav, we have not been using, I've never used midricane. Even in PG, I think we didn't use it when I did my PG from Mumbai. So I've never used it in my practice. So I don't have any experience of using it. I think it's the problem with subconjunctival injections that first of all, it's painful for the patient. And second is that the drug lasts for a very short time. The half-life in subconj is just about 2 hours. So it will not do much really. That's what I think. So I'd rather just make sure that the patient takes topical steroids and atropine. So I think I'll achieve the same thing.
Okay, ma'am. Thank you.
Which drug will you use for the mydriasis in uveitis? Means you are using steroid, and which drug as mydriasis you prefer and why?
So
I'm sorry, I'm asking all this.
No,
they should have asked all this.
Yeah, no, I always use atropine sulfate in 90% of my cases. And although some practitioners feel that with atropine, you might have the pupil fixed in one position and so on.
Yeah.
But the relief from the cyclitis and the role that it plays in relieving, in hastening the recovery for uveitis is tremendous. And I've not had a situation where I would attribute posterior synuclein to atropine, that it got stuck, the pupil got stuck, and it always comes back to normal. On the other hand, with home atropine, there is one problem. What happens is that because it only mid-dilates the pupil, so the incidence of pupillary block is higher with home atropine, and that's one of the reasons that I don't use it. And
cyclogic as cyclopentolate.
So cyclogic again, it's because I never use it, but 2 reasons. One is that it is very short acting. It is not as long acting as hometropine and atropine. And second is that based on what we know from its pharmacology, it actually destabilizes the vascular barrier, whereas atropine and hometropine act by, the mechanism of action is such that they stabilize the endothelial cells of the blood vessels. So they avoid the leaking of all the inflammatory cells into the aqueous, whereas cyclopentolate does not do that. So it does not really help for inflammation. In fact, you shouldn't use it during inflammation.
Yeah. Sharmishta is now switching on to the granulomatous uveitis. So how do you differentiate different etiologies in granulomatous uveitis? And or you recommend investigations in granulomatous, right?
Right, right.
Yeah. How do you proceed with that?
So granulomatous uveitis, they have to make sure that they don't have any other, well, it would be easier if they had any other telltale posterior segment signs, retinal lesions, and so on. So first of all, we have to do a very thorough examination for that, because just having granulomatous anterior uveitis and nothing else is less frequent. So the granulomatous anterior uveitis that we see, I make sure that my retina colleague has seen as well and rules out any posterior segment typical lesion that they can have. So once it's established as anterior uveitis, so just as I mentioned, that the test I would do would be the Mantoux test, X-ray test, serum ACE, and wait for the results of those. And once those results come in, then based on that, I would, if possible, get an HRCT test done. Say, let's say, for example, Mantoux is very elevated and X-ray test still did not show something. So
Mm-hmm. Yeah.
the reason why I chase the diagnosis here is because I do know that, of course, I would have started treatment and the uveitis will go down.
Yeah. You have muted the Shamshila, please unmute yours. Yeah.
I think I was muted by the tech team or something.
Okay.
Could you hear me in the beginning or the entire conversation?
No, entire thing is over. Just last few words.
Okay. Yeah, so I was just saying that the reason why I want to chase the diagnosis of whether the patient actually has some possible tuberculosis or something like that, because it will help against recurrent episodes, not for the primary episode.
Yes.
And it may help against the patient developing into a full-blown posterior uveitis and so on. And if all those tests are negative, or even if just Mantoux test alone is elevated, I don't push the patient into anti-tubercular therapy, because the systemic side effects of anti-tubercular therapy are worse than the topical medications with which the uveitis episode will go away.
Yeah, if the granulomatous uveitis is there and it is not coming down and you are investigated, all other investigations are negative, Mantoux is raised, and what else you want for starting ATT in these patients?
So I would get a quantiferon TT gold test done as well as HRCT. These two things are what I would do. But ultimately, it all depends on our clinical, almost you can say belief, or our conviction, whether this is tubercular or not. So if it has those typical mutton fat keratic precipitates and so on, you've seen those cases. So there I would probably have the patient start a course of ATT.
Because nowadays tuberculosis is a notifiable disease, and it need to be notified either by us or by the physician.
Yes.
And physicians really, they want at least three things to be positive, that is Mantoux, raised ESR, and either chest X-ray or quantiferon positivity. So in the absence of that, if you are still clinically you feel it is strongly towards tuberculosis, you can recommend ATT, but in conjunction with the general physician.
Yeah, but only thing, first episode I might just treat.
Yeah,
just the patient gets relapses.
Yeah. And second is that a lot of cases we see anterior uveitis of non-granulomatous variety with recurrences.
Right.
How do you proceed with that? Actually, you have nicely enumerated what is called recurrence. Actually, that is the more often we see that, because either people do give inadequate steroids, or
Yeah.
they stop very early,
Yeah.
and then there is a reactivation and they call it as recurrence, but it is not recurrence.
Exactly.
So real recurrences, how do you proceed?
Still,
It is
when
non-granulomatous,
Okay.
only anterior uveitis.
Right. No, but still, I would say that when these patients come back with recurrence, and we've ruled out that it's not the drug compliance issues or the patient using for 1 week
Yeah.
and stopping it. Still, two things I always get done is one is that examine them to see whether they have so many vitreous snowball opacities or vitritis and inferior. So sometimes you miss that, or it may not have been there with the previous visit. So you know that it's intermediate uveitis actually. You revise your diagnosis. And the second thing is the vasculitis component. So that for me, not being a posterior segment person, I may not pick it up, but FA would show that, or luckily I push my posterior segment colleagues to see it. So those are, first of all, we need to rule that and just highlighting that. But if everything is ruled out and we're convinced it's anterior non-granulomatous, so it depends on how many times the patient has the recurrence. So if it is something like 4 to 6 times a year, basically the patient uses eye drops. As soon as the course is done, again the patient gets a reactivation, compliant patient. Then I do have a rare patient or two where I've put the patient on oral immunomodulators. I don't chase the etiology because there isn't anything else to chase actually in investigations and so on.
Okay. Another thing which I observed clinically is that patient feels that redness is coming and there is a recurrence.
Yeah.
But when they come for the examination, there is no flare, no cells, and these are reasons of red eyes other than uveitis.
Right.
The patient wrongly coins it as recurrence, and they give the clinician an impression that it is recurring, which need to be ruled out in these cases.
Yeah, patient goes into panic mode when they get a subconjunctival hemorrhage and they rush and come to emergency, sometimes thinking that it's a uveitis has come back. So
yeah, now it is open for all the postgraduates, whatever they want to express. How many are there? Actually, everyone muted or the screens are off.
No, they are there. They are there.
do we have
They
more
need to be on the
questions?
screen. Okay, need to be visible.
Is anyone presenting any more
Yeah.
questions? Or?
You want to ask some questions? Pallavi? Yeah.
Ma'am, I want to ask one question. Whether we should give the combination with antibiotics, steroid and antibiotic combination, or steroid on eye drop steroid?
There is no need to give a prophylactic antibiotic for these patients. We've done that in clinical practice for years. And
That's what you have mentioned, Sonali. But what usually we from the very beginning at LV Prasad, we discouraged any use of combination therapies.
Yes.
Because certain times the drug effect you cannot attribute to the drug whether it is effective or not when you are using a combination therapy. Second is multiple drugs against multiple agents or etiologies should not be used. You should be very strong clinically to use a single regimen which can give you either you are right or wrong. The response itself will define you that whether you are in the right line or not. Okay, so you should not use antibacterial, antiviral, and antifungal in case of any inflammation or infection. You should not use that. That should be a basic principle for you to manage clinically. Yeah, anyone else want to ask anything?
Good evening, ma'am. I have one question.
Yeah, Rupa Gupta, yeah.
Yeah, ma'am. If the patient, when the patient came to the outdoor clinic, he's only complaining of pain, but when we see the slit lamp, there is only some old KPs are visible. So in that case, and there is no active cells of flare, should we treat in that case or we don't?
So we often have noticed that the patients have sort of a prodrome that they know because the cyclitis and the photosensitivity comes first. So those are the two symptoms that they have before we see full-blown clinical manifestations of uveitis. So once if I have a patient who has had recurrent episodes And even when they call me also, I just ask them to start topical steroids. So exactly like you said. So, or some of the patients may have already started and they come to you.
Yeah, they actually complain of they're having pain and having something blurry. But on examination, I see some attack of iritis was there. Like there is lens dispersion in the
past.
capsule.
Yes.
But there is like no cells or flare or there are no active KPs are there. So what should I start them on steroid and atropine or not? That's
No, I think that because you need to see, you want to treat the disease when you see clinical signs, and there are some differential diagnoses also for such symptoms. So
you should not.
Don't start
steroids.
Don't start steroids, and certainly don't start atropine. Otherwise, they'll be very unhappy with you because they'll have a total blur of their near vision. And in the exact situation you said, I wouldn't start anything. I would probably give lubricants as a placebo, so the patient thinks they're using some medication. Yeah, and
certain times the patient will lead you to wrong diagnosis. Actually, they complain so many because they are old patients of uveitis.
Yeah,
they know the signs and symptoms, and they may complain signs of symptoms of uveitis without any signs. Signs are not there. Don't commit for any treatment because uveitis is not 1 day or 1 week treatment. You need to understand this.
Also, they will come back because they came back with no disease. They'll definitely come back with disease. So you will catch them at the right time to start.
Yeah.
There is a question in chat box.
Please read out.
Dr. Santosh Mahapatraja asked the question: what is your opinion regarding AC tap for CBNAT in inclusive case of clinical suspect of tubercular uveitis? What is your opinion regarding AC tap for CBNAT? What is the CBNAT?
CBNAT PCR, sir.
PCR.
Achha. In inclusive case of clinical suspect tubercular uveitis.
ACTAP has not shown the promise that it was showing earlier for tubercular uveitis. Yes, we can do that, but I'd rather not do an ACTAP for tuberculosis diagnosis. We have stopped doing that. For tuberculosis diagnosis, either we do all the tests that Dr. Ajit had discussed just now, the 4 tests being Mandel's test, X-ray test, quantiferon TB gold, and HRCT. We do those, and or if we still have a strong clinical suspicion that the signs fit very well into a diagnosis of tubercular etiology, we go ahead and start treatment. So we don't do ACTAP.
Yes.
I'm sticking to anterior uveitis. Let me just qualify that.
We have one panelist, Dr. Rajinikanth Sinha. Would you like to say a few words, Dr. Rajinikanth Sinha? Sir, are you there?
If there are
yes, sir. Any comments from you? Yeah, please.
What I believe is that if there are symptoms of pain, redness, and tenderness, one should go for therapy or should not wait for KP to appear. Right?
Yeah. Agreed.
The example that she gave was that the patient just simply feels some kind of a pain or something like that, and there are no KPs and no redness. So that is even before any signs.
No, if there are any flare cells and red pain and photophobia,
ciliary tenderness is there.
Start
Treatment
even without KPs.
If there is ciliary tenderness without KP, that means he is under treatment from some other doctor, and that treatment is hiding the feature of KP and etc. It must be under treatment from some other ophthalmologist.
Right.
That's a very good point. As I had mentioned in my presentation, that patient on treatment will have a different kind of
presentation.
Yes. So I think it's time to stop, I believe.
One last
As you
question.
like, BNR.
Yeah.
Rosal has raised her hand.
Yes.
I just want to, thank you, ma'am. Such a delighting talk as usual. I just want to we have discussed so much about the investigations, even the ACTAP for polymerase chain reaction. But I just want to highlight that even we have to take a thorough drug history because sometimes if we start ATT and comes with a hypopian uveitis, doesn't need to be investigated for the same. It's well known that rifabutin and many other drugs, they cause hypopian uveitis. So drug history is equally important in any case of anterior uveitis.
Important, very important. Yes.
Secondly, all the patients with an history of recurrent uveitis with a complaint of low back pain or any joint pain need not be referred to rheumatologist. There is something called duet algorithm which we ophthalmologists should be following before referring any such patients to rheumatologist.
Yeah, thanks, Ghazala. Nice to see you here. I deliberately didn't bring in the duet algorithm because I thought that we're starting off with the first, second, third year residents. And as a teaching kind of an exercise, the duet algorithm is good for if you're already in practice. And it's good for them to know also. Maybe they should anyway read it up. I agree with you. And the drug history is one thing I overlooked in my presentation. But drug-related anterior uveitis also is a fairly common entity, and many drugs can cause it. So thanks for bringing that out.
Somashila, can I ask a question? Ashok here.
Hello, Ashok.
Yeah, Ashok Nanda, please.
I think this is the last question, which I suppose. Where would you
not seeing your face? Where are you?
Sir, I just changed my.
Doesn't matter. Please ask the question. Let us not waste time.
The question is, where do you prefer to give a cyclophosphamide versus azathioprine versus I mean, all those immunomodulators? Do you have specific areas where you choose one immunomodulator to another? I mean, when you talk of non-steroidal immunosuppressants, any specific case where you decide to?
So, because the topic is anterior uveitis.
Anterior uveitis, it is not so important, Ashok. Probably in the next class on posterior uveitis, it is much more pertinent.
But there are cases of juvenile rheumatoid arthritis where there are a lot of recurrences. We do have to give long term.
So for so for GIA, typically either methotrexate or if a little bit affordability, then mycophenolate mofetil is the starting medication. So methotrexate is the starting is pretty much what most of us would use for these patients, or rather, again, the rheumatologist would be in charge of this patient primarily, but sometimes we have to co-manage. And these patients don't need cyclophosphamide. Certainly, you don't give them cyclophosphamide, but there are other agents, certain biologicals like ADA or certain other agents, adalimumab, that can be given for pediatric patients. But that is a long discussion. But from the anterior uveitis component, for the anterior uveitis, it's a kind of a mixed combined therapy. Both the topical medication as well as what is going on systemic, both will help us control the disease.
Okay. Right.
Any other questions? Mainly.
Hello.
Arnab has asked, Sonali has asked, and Rupa has asked. Pallavi, you are very silent.
Excuse me, sir.
Yes.
Sir, what is the role of oral steroid in anterior uveitis?
Anjani, no? Dr. Anjani?
Yes, sir. Anjani here, sir.
Yeah.
The role of oral steroids in anterior uveitis.
Somshila, in which cases do you really consider oral steroids? She has briefly mentioned, but
I did mention it, Anjani, that it's very rare that I use oral steroids.
Yes.
I would use frequent topical steroids or diflupred, which is a potent steroid, at least for the initial couple of weeks, and prednisolone acetate 2-RD/1-RD. Some of these patients come in with, let's say, the HLA-B27 kind of patient came in with a hypopion uveitis and sort of an occlusive membrane on the pupillary area. So for these patients, I might add oral steroids. I don't do a full therapy like 1 milligram per kg body weight. It may be less than that. So maybe 50 milligrams for a couple of weeks, and then I stop that and continue with topical medication. So oral steroids is luckily is very few, maybe the pediatric patients with VIA. That's one other indication that I can think of where we have to start some amount of oral steroids as a bridge therapy to get the inflammation under control. And these are two main indications. But it's a good thing you asked this question, because a lot of practitioners are in the habit of starting oral steroids for anterior uveitis. It is, honestly, it's not required. The disease gets very well controlled with topical medication.
Actually, that statement is very important because considering oral steroids is very, very last resort. You should not really consider oral steroids in pure anterior uveitis. You need to rule out all the other components of uveitis.
Ma'am, and regarding the topical steroids, the frequency which we normally use in our OPD is 2 hourly initially. So is there any protocol that we have to start with 2 hourly only, or we can start 6 times or 8 times? We have to start 2 hourly only, like prednisolone?
No, she already covered that it is not mandatory that you should start only 2 hourly or only 6 times, as Sonali told. It all depends on the severity of the anterior uveitis and presentation.
And how the patient responds.
Yeah, yes,
responds.
exactly.
Yeah.
So you should start with one regimen and then see maybe 3 days or 1 week as it is convenient to you and the patient. And then see the response, how it responding. Then you should consider either increase or decrease the frequency of
but it is good to start. It is good to start aggressive. So you should
aggressive. That much is
correct.
I would say it's a pretty good sort of a average. You're averaging it out for the severe patient as well as not so severe. So you make it too early. So when it's a protocol for the institute, then it's a good protocol.
Good.
So can I ask one more?
Hello, sir. I have one question.
Yeah. Yes, carry on, Pallavi.
Yeah, ma'am, regarding steroid administration, is there any role of other routes of administration of steroids apart from topical in acute anterior uveitis?
So except if there's CME, if there is no CME, it's topical. For CME, then you can give posterior subtenon for the CME part. So to answer your question, it's topical. And I mean, I'm not sure if that's the answer you're looking for.
Okay, ma'am, second question, is there any role of plasminogen activator? Like, ma'am, you told like there was fibrin component in, like in this case, which was discussed here.
You know how much that costs. It means you don't know how much it costs.
Yeah.
It's very expensive.
Okay.
If it was dirt cheap, you could have used it, but it's very expensive.
Okay.
So I think it's 50, 20, 30,
it
40,000.
is almost like 20,000 rupees per one vial. We get it for subretinal hemorrhages we use, but in different doses I give in 2 or 3 sittings. But it is too costly for it to start in anterior uveitis. Usually we don't see so much of severity of anterior uveitis that do not respond to topical steroids or mydriatics. Usually they respond. So let us not go for the very
Atropine will do that for you.
treatments which are not so good.
So atropine will do the same thing for you, much cheaper.
Yeah.
And
It breaks the synechiae. Early synechiae, you use atropine, it breaks the synechiae as well. So that is another aim in treatment of anterior uveitis. Biswanath Sahu, he was very active in the very first thing that he wanted to present the case, and after that he was silent. Biswanath Sahu, do you have any questions?
Unmute yourself. Unmute.
He's not unmuting. Okay. Anyhow, before BNR give the concluding remarks, I want to thank Sonali. Sonali, it's very nice of you that you came forward and did the case presentation. You have done very well for the first exposure for almost like a webinar with so many people around. It's tough to present, but you have all the boldness. That's what we want. You need to be bold and expressive. We can correct ourselves. We all do a lot of mistakes. We can correct ourselves, but unless you express, unless you come forward, that cannot happen. Okay, so it's good that you have stood as an example for rest of the postgraduates, so that next time someone else will get prepared their case. But I request all of you that you should have a case presentation with a definitive outcome and with some results of the investigations. Okay, treatment plan we know, but if treatment response is there, then we can correct it or modify it or improve it, or we may adapt it. Anything can happen. Okay, and Shobhashila, thank you very much for accepting our invitation. It is East Zone, and you are exposed to all the postgraduates in the East Zone, and it's very important for us to learn from you.
I would say it's the other way around. I think I learned in return. And thank you so much for having me. This is wonderful. I'm sure the postgraduates will open up more and more.
Great.
And I just enjoyed the entire session today. It was really nice. And I think this is a great format for PG, the residents to learn. It's up to them. They should ask more questions.
Good. Yes.
And you have the best of masters sitting over here, the really top scholars sitting over here as your panelists and as the committee. So I think the postgraduates should make the best of this.
At the beginning, I told you you must activate the postgraduate students. They should come out.
Yeah,
they should come out of the hibernation and they start speaking and asking questions. So it's really wonderful. It's a wonderful